Hi, I'm Don Berwick. I'm President Emeritus and Senior Fellow at the Institute for Healthcare Improvement here in Cambridge, Massachusetts. I wish I could be with you in person, but I'm privileged to get to join you this way. And thanks for the opportunity. I've been around the area of healthcare improvement for a lot of years now, over 30 in my career. And I remember the time when we reached a turning point in the year 1999 and 2001, when the Institute of Medicine, the National Academy of Sciences, now the National Academy of Medicine, undertook on its own initiative to do an overview of the state of quality in American healthcare. And I had the privilege of serving on that committee and helping write the reports that became To Err as Human in 1999 about patient safety, and then 2001, Crossing the Quality Chasm. These reports mark an inflection point in our dealing as a nation with the need to make our healthcare better. Until that time, we had a collection of research and inquiries that amounted to an evidence base, but we didn't know it quite to that level of precision until the Institute of Medicine took it on. What happened was remarkable. A very conservative body, the National Academies of Science, said we have serious problems in the performance of healthcare in our country. It, as you know, dimensionalized those problems in terms of a set of aims for improvement that have since become famous. They're emblazoned on the wall here at IHI, and they've been absorbed thoroughly into your organizations. The aims were safety. Stop hurting people in care. Let's make care as safe as we possibly can, instead of giving people a burden that from the errors and injuries we cause in care. Safety. Effectiveness, that meant let's align care better with science. The Institute of Medicine found enormous variability in what happened to people when they entered healthcare. The way they were treated really had much more to do with their zip code than with their disease. In fact, the variations were phenomenal. Notice of the Institute of Medicine, that's not good. We need to be consistent in adhering to science so our patients have the best possible chance of the outcomes they want. Safety, effectiveness, and patient-centeredness. The Institute of Medicine said we're not patient-centered. We configure systems for our convenience, not the people we serve, and we don't honor and respect people for their preferences, their values, the resources they bring to us with their communities, their special desires. We don't orient ourselves around the question that Maureen Bisignano and Susan Edgman-Levitan have now taught us: what matters to you, instead of just what's the matter with you. Safety, effectiveness, patient-centeredness, timeliness. Delays are poor quality unless they're instrumental, unless we're doing it on purpose. When we keep someone waiting, it increases harm, it absorbs resources, it's not quality. Safety, effectiveness, patient-centeredness, timeliness, efficiency. Waste is poor quality, and our systems are rife with waste. Forms of care that can't possibly help people, but we do it anyway. Defects in our care that cause things to be repeated, administrative burdens, and a raft of complexity in the healthcare system that just takes money with no value added. And the last of the six aims was equity. Maybe the most important of all, that in our country, in our great country, said the National Academy, still the color of your skin, the size of your bank account, that's what's determining your health status more than anything else, and it's unfair, it's wrong, and it's poor quality. Safe, effective, patient-centered, timely, efficient, equitable care. Those became our goals as a nation when the National Academy spoke out. That got beefed up a bit, I'll say, thanks to the work of colleagues of mine here at the Institute for Healthcare Improvement in 2006 and 2007. Tom Nolan, my mentor, and John Whittington, a generalist physician from Peoria, Illinois, and a member of the IHI faculty, said that's not enough. Safe, effective, patient-centered, timely, efficient, equitable care, absolutely. But why do you need care? Where did your heart attack come from? How come you broke your arm? Why are you depressed? And we know the answer to that, and that is the causes of illness do not lie in healthcare. They lie in communities. They lie in the way we move, the way we eat, the way we treat each other. They lie in our commitments to social justice and equality. They lie in poverty. They lie in the environment. And Whittington and Nolan said we have to move upstream, not just better care, but better health. Better care for individuals, better health for populations. And the third of the triple aim, lower cost per capita. Why? Because every single dollar that healthcare uses comes from somewhere else where that dollar is also needed. If it's government paying, it's coming from our schools and our roads, from our housing, from our transportation. We need that money, and healthcare doesn't have a right to it. It doesn't have a right to take money that it doesn't put to good use. And if you're in the private sector, that dollar's coming out of the pocket of a laborer who needs it to go to the movies tonight or send their kid to college, or the pockets of a company that's contributing to healthcare and therefore cannot pay their employees more, cannot reduce their prices in a globally competitive marketplace. So Wilmington and Knowles said the aims are better care, better health, and lower cost. How do we get there? Through change. We have to change the way we deliver care in our systems. No amount of exhortation, no amount of beating up each other, not even any amount of incentive will change it. Until we reconfigure healthcare, we're not going to have better care, better health, and lower cost, and we desperately, desperately need it in our country. And that brings me to you, Joel. It's such a privilege to get to celebrate your career, your contributions, and your character as a human being, and for me, your friendship. Thank you. Thank you for your local and global leadership over the past 16 years in addressing those 6 aims for healthcare quality that I just described, and indeed the triple aim itself. Joel, you were prescient, remarkably prescient, as a new chief executive in 2000, and recognizing the importance of communicating those aims to your growing group of employees and stakeholders now for an organization with more than 40,000 employees, one of the largest accountable care organizations in the U.S., with 5,000 affiliated doctors, one with a healthcare delivery geographic footprint covering more than 60% of Texas. The STEEP acronym that you coined and that you put together in your wonderful book was brilliant to help everyone, all your employees, all the stakeholders embrace your commitment to these aims, to recognize the daunting, steep challenge that we face each and every day in improving care in Texas, in the United States, really around the world. Joel, you've walked the walk. You haven't just talked the talk. I think I've heard, to paraphrase an expression I've heard in Texas, your leadership isn't all hat and no cattle. Your accomplishments are well known, and you have the respect of an industry. I want to underscore just a few of those accomplishments. Your heart hospital in Plano, Texas, it's recognized globally as one of the most exceptional places in the world for safe cardiac surgery. It has a remarkable 3-star STS performance for all 3 categories of STS measurement, including your Associated Heart Hospital in Denton, which has no in-hospital deaths, none, since it opened in 2014 among more than 347 patients undergoing cardiac surgery to date. Safety, effectiveness. You've made remarkable strides in timeliness, with PCI times for patients with acute myocardial infarction now with median times far below 30 minutes. That eclipses dramatically the performance metric of 90 minutes that we initially envisioned back in the 1990s for patients with acute myocardial infarction. Your ability to implement standardized order sets when they count across your enormous network of acute care hospitals long before most organizations were even starting that journey. Well, you set the bar for effective care with the particularly poignant example of heart failure. We would save annually across the U.S., I think, more than $2 billion, more than 15,000 lives with other hospitals if everyone achieved your performance in delivering clinically effective care. Regarding efficiency, your waste reduction efforts to enhance efficiency have been courageous, and especially because in light of the negative immediate impact that has on your bottom line, because you're dramatically reducing overuse of imaging for patients with acute low back pain. That hurts your bottom line, Joel, but you're committed and you're walking the walk. When I was leading CMS, I personally had the opportunity to view your work firsthand on healthcare equity. I so well remember my visit to the Juanita Craft Health and Wellness Center for Diabetes in Dallas, where you walked me around in the area of Dallas just fraught with staggering levels of poverty and violence. Your community health workers, they were setting a national standard for how to engage community residents through motivational interviewing and other innovative techniques to assist community residents in optimizing their health status and related quality of life. It looked real to me, Joel. I met members of the community and saw a system really organized around the determinants of health. When I visited your heart hospital at that time, I remember your work on readmissions, which was actually setting the national standard for readmission rates. You're not just talking about results, Joel. You've gotten them. In your Steep Care book, your focus on patient centeredness was recognized early in your leadership as CEO through the inaugural Leapfrog Patient Centered Care National Award in 2007. Most recently, I think in November of this year, the Press Ganey Community Response Award came to you. And while your work in Texas has been remarkable, pace setting, equally important, your organization's been a global leader, Joel, in helping others to make progress related to the 6 aims of healthcare quality and the triple aim overall. My colleagues and I at the Institute for Healthcare Improvement view Baylor Scott and White Health as an exemplar organization, as described by Steve Swenson of Mayo Clinic in IHI's 2013 white paper on high impact leadership. So Joel, thank you. Thank you for your remarkable leadership as the CEO of Baylor Scott and White Health. I know that I and others will continue to seek out and benefit from your wise counsel as we continue to pursue steep care aims globally. And let me add thanks for your friendship, Joel. At every turning point when I've come to you for advice or guidance, for information I needed, or for just good thinking, you've been there for me. I'm deeply grateful for you, for your leadership, for your example, and I look forward with excitement to following what your next chapter is, Joel. Thank you so much.